Um, Assalamu alaikum. I am Dr. Fatima Dashti, consultant pediatric neuroradiologist in Ibn Sina Hospital, and I would like to talk about CNS infection in pediatric population, trying to cover as much as I can in this short time. And the most points that I would like to talk about are the common CNS infections in pediatrics, as well as the major complications. And complications of CNS infections is maybe it could be the main reason for imaging these children, as well as response to therapy, check the response of therapy and sequelae of the infection. We know that ultrasound is an easy, free, radiation-free, easily accessible bedside tool to use for infants, especially in those in PICU and NICU. And it's helpful in screening for complications such as hydrocephalus and extracranial collections. However, CT is needed, cross-sectional imaging using non-enhanced CT is needed in patients such as those who have signs of raised intracranial pressure or focal neurological deficit or altered level of consciousness. Enhanced CT should be preserved for those who would not, who are unstable and would not be able to perform MRI for. And it's good in detecting collections, abscesses, empyema, as well as leptomeningeal enhancement and vascular changes. However, MRI is the best diagnostic modality in imaging these patients, especially by the use of diffusion-weighted imaging and enhanced sequences. And it is very eloquently delineate the extent of the parenchymal involvement, as well as gives us the chance to image vascular structures as well as the spine. I'm going to start talking about congenital infections, and usually these infections are related to viral infections. And the most common ones are torch infections. And we have to realize that these infections affect the developing brain. And it is the timing of the insult is more important than the type of pathogen in determining the outcome. And also the virulence or the severity of the infection will determine the severity of the outcome. So in early pregnancy, we are more likely to see severe congenital malformations than in later pregnancy. This is an example of a child who was referred to us with to rule out craniosynostosis. This child had microcephaly, and we can see that there is cerebral atrophy, intracranial calcifications, and ventriculomegaly. And this child was diagnosed with CMV infection. And these children would commonly have developmental delay, hearing loss, vision loss, plus other abdominal systemic findings. And the clinical triad of microcephaly, seizures, and deafness is highly suggestive of congenital CMV infection. So as I was saying, if the infection was early in the pregnancy, we are more likely to see things like microlissencephaly. Of course, with intracranial calcification and some ventriculomegaly. But if it happened in later pregnancy, we are likely to see things like pachygyria or schizencephaly, polymicrogyria and schizencephaly. But in any way, we commonly see intracranial calcifications that is usually periventricular, as well as white matter involvement. And the white matter involvement can vary from severe necrosis to just signal changes like we see here in these cases. And the differential diagnosis would be metabolic diseases or other congenital anomalies secondary to genetic diseases. Another differential for congenital CMV infection is congenital toxoplasmosis, because these children would have convulsions, developmental delay, intracranial calcification. However, children who have congenital toxoplasmosis tend to have macrocephaly because of hydrocephalus, in contrast to the children with CMV would have microcephaly. Another viral infections that affect pediatric is in postnatal, of course, is the viral encephalitis. And the viral encephalitis usually affects the cortical and the deep gray matter structures, but it can also involve the white matter commonly within the splenium of the corpus callosum or within the brainstem. And diffusion restriction is a good indicator of areas of necrosis. And a lot of these pathogens have tendency to affect certain areas in the brain, similar to herpes simplex encephalitis, where the affection is usually related to the temporal lobe and limbic system. Sometimes it's bilateral, but it would be asymmetric. And as we see here, the extent of the diffusion restriction indicates the extent of parenchymal necrosis. And we have to realize that these vascular viral infection can also cause vasculitis, and we can have some hemorrhagic transformations within these areas. Another reason for hemorrhagic encephalitis would be acute necrotizing encephalitis, and this we see secondary to influenza A and human herpetic virus 6 infections. And sometimes these are commonly seen in patients or families who have RANP2 mutation. And in these cases, we will see diffuse prominent thalamic swelling and edema with involvement of the brainstem and cerebellum. And if we do a MRI with gradient echo and susceptibility weighted imaging, we will see areas of vascular hemorrhages, and this may not be evident on CT. And it's very important to recognize because it is with very poor prognosis. This is another example of predilection of enterovirus D68 that has predilection for posterior brainstem and spinal cord involvement, and it was reported in an outbreak in 2014. And talking about outbreaks, we have to talk about COVID-19, and we know in this epidemic era there have been reported cases of adults with CNS involvement with encephalitis or vascular events. However, in pediatrics, there were few reports of similar changes. One report of 27 patients who had symptoms found only findings on imaging in 4 of them, and they had splenial signal changes and diffuse brain edema. However, there were 2 reports about vascular involvement in such patients who were COVID-19 positive. One had a stroke secondary to MCA and stenosis, and the other one was from our group in Ibn Sina Hospital, who had the child had a large left cerebral hemorrhage secondary to ruptured pseudoaneurysm. Another important infection that we have to discuss is the bacterial meningitis. And bacterial meningitis is very important, especially in the neonates, because again, it will affect the developing brain. So meningitis is more common in infants, and within the infants population, it is more common in preterm. So it can have very serious sequelae. And in these patients, ultrasound is a very helpful tool for screening, for initial evaluation and follow-up. However, a cross-sectional imaging is needed in many of these patients. especially with complications. And we need to look for to have enhanced CT. However, the enhanced MRI is more better in delineating meningeal enhancement, and it is known that enhanced T2 flare is more sensitive than enhanced T1 in delineating leptomeningeal disease. Like we see here in this case, there is the extent of leptomeningeal enhancement on enhanced flare is more than we see on 3D SPGR. So the complications of meningitis are many, and a lot of them are really serious. But one of the most common complications are extracranial, extraaxial collections. And we know that empyema and effusions can be hypodense or hyperintense to CSF. However, empyema will have diffusion restriction and marginal enhancement in comparison to effusion. And this is very important to recognize because these collections usually need surgical intervention, unlike effusion, which resolves spontaneously. Another collection can occur within the ventricles, and these collections are secondary to ventriculitis, which is due to choroid plexus involvement. And the collection of diffusion restricting pus or debris will usually be seen within the occipital horns with associated dilatation because of obstruction of CSF movement, either because of the viscosity of the CSF or obstruction of the of the arachnoid villi. However, the hallmark of ventriculitis is the smooth ependymal enhancement, and it's very important to look for these signs because ventriculitis can lead to adhesions and loculations and multilocular hydrocephalus. However, hydrocephalus can also occur in the absence of ventriculitis secondary to direct obstruction at any level, even at the level of absorption. And in these babies, whether with ventriculitis or with hydrocephalus, using fast MRI sequences without sedation, without having to sedate the babies, is best used to follow up the CSF spaces because they tend to have many imaging, frequent imaging. Another important complication is vasculitis, and in these patients there will be parenchymal ischemic changes and infarctions that will be seen in, on diffusion weighted imaging as areas of diffusion restriction. And this is the way to separate them from focal cerebritis, which will show no diffusion restriction. And these also, we can see some areas of secondary hematomas, intraparenchymal or extraaxial. And sometimes when they are, and of course when they are diffuse, it has very poor prognosis. Arteritis as part of vasculitis can involve perforating arteries leading to lacunar infarcts, especially at the basal ganglia or watershed areas, but it will also cause can also affect the larger arteries, and this will lead to territorial infarctions, and if they are large and many, it has a grave consequences. Venous thrombosis is also a serious complication of meningitis, though not common, and it can be evaluated by MRV. However, enhanced sequences, especially enhanced MRV or enhanced T1 3D, are best in delineating even the small thrombi in comparison to time of flight, because time of flight venography can have flow artifacts. There can be also involvement of the medullary veins that is best seen on susceptibility weighted images with the secondary areas of ischemia and necrosis and possibly hematoma. Brain abscesses can occur secondary to meningitis, but they are more commonly secondary to direct inoculation or hematogenous spread. And usually the prognosis better the older the child is, and it can be polymicrobial. So on imaging, of course, it would be cystic with marked bililesional edema. The wall shows smooth enhancement that may be thicker towards the cortex, and it will show diffusion restriction. However, the wall will not show increased cerebral blood flow or cerebral blood volume on perfusion. So the mark, if there are bilateral lesions in the brain, we have to check for congenital heart defects causing left to right shunt. On SWI, it is reported that it is seen that the wall of the abscess can show smooth hypointensity that correlates with the smooth enhancement of the abscess. And a more specific sign that was described with abscesses is the dual rim sign, where we will see an outer hypointense rim with an inner hyperintensity, can be both seen on SWI and on the T2. However, it is known that diffusion weighted imaging is the best or one of the best sequences that differentiates brain abscesses from other brain cystic brain lesions, and the restriction can be to a variable degree, and it can be this sequence can be used in monitoring response to brain to therapy, whether surgical or medical, like we see in this case with a baby who had multiple posterior fossa abscesses and had multiple, and also had hydrocephalus, and we were doing multiple frequent imaging for this baby using our fast MRI protocol, and we were able to see on diffusion the changes within these abscesses, and we were also able to detect the new abscess that was coming on, while the other ones were decreasing in size, and we had, and also we can see the reduction in size post aspiration. So neurocystocercosis is another ring-enhancing lesion that we have to recognize in a pediatric population, though it's not common in our part of the world, but we have seen few. However, there will not be a similar diffusion restriction, and the cyst tends sometimes to have some inner heterogeneity because of the presence of scolex. A differential diagnosis to abscess is dermoid cyst. So this child had two posterior fossa diffusion restricting lesions, but they had a little bit of difference in the appearance on DWI and in the wall enhancement. And I want to point to draw your attention to the defect here in the occipital bone with the extension towards the skin, and the neurosurgeon confirmed the presence of a punctum that was covered by hair, and the diagnosis was made by of an infected dermoid cyst with secondary abscess formation. And this image can nicely show the difference in the enhancement pattern between the two lesions despite the presence of marked edema. So ruptured dermoid cyst is a strong a main differential in such an abscess in pediatric population, because it can have a diffusion restriction, and when it ruptures, this diffusion restriction can be seen in the extraaxial spaces and within the ventricle, similar to cases of meningitis. However, the enhancement pattern and the edema are different. Sinus involvement, dermal sinus involvement is very also a differential is very important to recognize when there is discharging dermal sinus or recurrent sinusitis, and it can happen post-surgery. Infection can happen post-surgery, like in this patient who has collection, diffusion restriction with enhancement post-op. The child was not getting well, and this infection was confirmed by surgery. Another important one is presence infection of VP shunt in patients with hydrocephalus, and this also can cause multilocular hydrocephalus, and using 3D T2 brain lab is very useful in these patients, or using fast sequences rather than our routine MRI under sedation. And so in conclusion, MRI is the best modality for imaging in CNS infection in pediatric population. DWI and enhanced 3D-T1 and FLAIR sequences should be part of the infection protocol, and we have to correlate our imaging findings with the clinical suspicion to rule out other differential diagnoses. And pattern of imaging features is very useful in differentiating different types of infection to aid in the early management of these patients. Thank you.